What osteosurgery is, it's treatment from the top down, coronally to apically. This is apical to coronal. It's a big difference. That's how we get regeneration. And that's what really this is all about. I think when I look at this slide, I have to say that it makes the point of this lecture very worthwhile, at least to me, because it gives you something new. It gives you a new talking point in your arsenal to have that conversation where the patient is not going to roll their eyes and say, you know, not that again. You've been telling me I need periodontal treatment for 5 years. I really think it's important for you to have this information, because if you can get people treated, you're doing them an incredible service, not just so they keep their teeth, not just so they can eat, not just so they can smile. Maybe they'll live longer. Maybe. That's what the evidence indicates. So by giving them the avenue to do that, it gives you a new talking point. Because hygienists are the guardians of periodontal health in the general practice. You guys are advocates. You're certainly educators. Don't you educate all day? You know, you're really responsible for oral health in your practice, and the general dentist who you work with, their job is to fix what you find, to fix the disease and make it go away. But it's your job to find it, mostly. So you certainly have a passion for what you do, and you have a passion for treating periodontal disease, and maybe knowing that this is out there may make that easier for you. Let's look at some clinical stuff where I can show you kind of what this looks like when we're doing it. This is what it looks like at the end. So we're working backwards. This is the seal, the fibrin seal, and this is the poaching that I was talking about. This laser does not burn blood, it poaches blood. I used to have a different laser. 10, 15 years ago, I actually had a different laser. There was something big on the market. That's why I know the difference. It was a carbon dioxide laser. There were a few around in town, and they, you know, there were some periodontists around the country who were using these to do certain procedures. But it's nothing like what I'm showing you now. What it would do to this, instead of being red around the marginal gingiva, it would be black. It would be charred blood. Okay? Maybe you've seen this. I sold my CO2 laser for veterinary use. I did. It's now used at your veterinarian. But you know, that proves that just because it's out there, just because it's a cool device, doesn't mean it's worth anything. And that's where this is different. So what we're creating is a fibrin barrier, and that's not food, that's fibrin. That's part of that blood clot, that whole clotting sequence. 7-day post-op, 7-month post-op. Not great plaque control, but pretty good tissue. And I've seen that, by the way. I should say I've had my laser for 9 months. Let's see. Maybe 10 months. 9 or 10 months. And one thing I've noticed is they'll come back with plaque. The tissue's unbelievable. It's really unbelievable. Now, I'm not advocating that they keep the plaque, but it's just kind of nice to see. And this is really what it looks like. First radiograph. Looks like an implant to me. Maybe not. So that's after. Interesting. That's a pre-op.
Now, is this your radiograph? Is this your personal radiograph?
It is not. And thank you for asking that. And since you asked that, I'm going to show you radiographs. I haven't had the laser long enough to have a slew of this. This is a 5-year post-op. Okay. let me explain to you that the reason I'm showing you radiographs from others is to make the point that it can be done by others, not just by the guys in California that thought of it. It's universally getting this kind of result. That's why I'm going to show you other radiographs. Now, I do have one set of radiographs that I did. In fact, I took one last week that I was very happy with. So I'm going to show you the one. But the people, these are other clinicians, but it proves that it's working for, for other people besides the people that founded it. That's pretty impressive. I don't know why she put the arrow there. To me, I was impressed by this, but she was impressed by the distal. This is incredible. Now let me say something about this. These are abnormal results. We're not used to seeing stuff like this. We're really not. I mean, people would, cynics would say, well, this can't be the usual outcome. Well, it can be, but you have to understand there's a protocol. There's a lot of occlusal equilibration going on here. There's a lot of plaque control going on here. There's a lot of follow-up, and there's a lot of following directions very specifically. So this isn't an experiment. It's not like, a high school experiment where a patient comes in and we kind of fiddle around. This is what I was talking about. There's a protocol. But that's unbelievable. This is unbelievable. That pretreatment certainly would be a referral for an implant in all probability. Now that is really crazy for 4 months. I actually thought it was a misprint. Even if it's 4 years, I'll take it. But, again, these are results that we're just not accustomed to seeing. If you could get results half this good, I think you'd take them, right? Look at this. Now they measured radiographic density over time. So more dense bone had a different reading. And that's very impressive. Let me say something about this. And I have a couple of cases that I've done. In the lower anterior, one of the caveats, one of the rules, you can't have mobile teeth to do the procedure. The teeth have to be splinted. So you can see that those teeth are splinted. So I have a couple of cases just like this. I don't have, it hasn't been long enough for me to show you slides. I'm hoping that I have slides that look like this eventually, of course. But the teeth were splinted, and they have to be. So that's one of the rules I was talking about. You can't really have mobility for this to work.
But earlier, and you had mentioned the occlusal trauma.
Yes.
And of course, I would expect that you would, take them out of trauma, the occlusal trauma. But what about putting them into a bicarb?
Afterwards, after the treatment, a lot of patients need bicards.
Okay.
And that's important because the regeneration goes on for months and months, and you want to get rid of parafunction. So a lot of patients that have this done, they need to have night guards. So what I do is I send them back to the general practitioner and have them make a night guard. I also send the patients back for the splinting. I don't do splinting. So what I do is if the patient gets referred and they have mobile areas and I feel it's an area worth treating, I send them back and we talk about splinting. It can be some sort of bonding, wire and composite, whatever they want to do. But we can't have mobility. So here's a laser, a Lannett pre-op. And this is immediate post-op. And you see the tissue is intact. And that's 9 days. But you see there's no recession. It just looks like great tissue. It just looks like great tissue. So, that's just something that I don't think you can anticipate with conventional treatment or the treatment that we've been doing all along. Not that there's anything wrong with it. I've been doing the same treatment you've been doing. So here's more. And I love this. You're going to love this. 4 months, 6 months, 8 months, pre-treatment to 12 months. Not bad. All different practitioners, maybe all different levels of expertise. I don't know anyone's educational background of the slides I'm showing you, the clinicals, but I know that it's just a random sample of real LANAP radiographs. So that tells me that it can work if the protocol is followed. Yeah.
Are these all done with just one treatment?
Yeah. Yeah. That's kind of hard to believe. But you know, these are legit. I want you to know. They're not doctored, they're real.
Have you had any conditions in which a patient has been on, the Fosamax or the Boniva? And
Well, that's a whole different area, and frankly, it's really not a concern at all.
okay.
I've done implants on patients that take that. I don't think there's any issue at all with this procedure and
Being on those meds. Okay.